It's my great pleasure to introduce Dr. Heather Richardson. I always feel nothing but compassion for people who've experienced the flight to Australia. So a round of applause because she got on the plane. Heather Richardson is the joint CEO of St Christopher's Hospice in the United Kingdom. In 2014, she was awarded the International Palliative Care Nurse of the Year by International Journal of Palliative Nursing. She's a registered general and mental health nurse. She has a master's degree in health management and a PhD. And prior to her current role, she was National Clinical Lead for Hospice UK and Executive Lead for the National Commission into the Future of Hospice Care. And she's also an honorary professor at Lancaster University. Please welcome Dr. Heather Richardson.
Good morning, and thank you very much indeed to Palliative Care Victoria for the invitation. I heard Michael Bramwell speak probably about 15 months ago in Bristol, and I remember at the time thinking, I really need to go to Australia and to understand better what they're doing that we've got to learn in the UK. And so it was absolutely fantastic to get a letter inviting me to come, and I've had a thoroughly terrific time so far. So thank you to Adette and the team and to everybody who's made me feel so welcome. I'm going to talk today about the good, the bad and the ugly of hospice and palliative care in the UK. Just by way of a couple of disclaimers, these views aren't necessarily held by my organisation. They're certainly not held by everybody in the UK. But I think one of the benefits of these kind of conferences is to talk honestly about stuff that goes well and stuff that doesn't go well. And so I've taken a very honest approach to this. And if you don't like it, well, fortunately, I'll be going back on the plane on Saturday. If you do like it, I'd love to have further conversations, and there are lots of questions we face in the UK that I think you're facing here. The other thing to say is I'm going to talk a lot about hospice care, but I actually think that the majority of what I'm going to say is about palliative care more generally. It's just that that's my stable at home. So please forgive me for that. And I'm going to make a lot of reference to end of life, and I honestly don't know what the difference between end of life and palliative care is, and I spend a lot of time debating it in my head and externally. So let me start by telling you where I come from. St Christopher's Hospice was the vision of Dame Cicely Saunders, and it was where she took her vision, her aspirations, her beliefs about the way people should die, and she built an organisation, this is the building itself, in which she could enact it. And her vision then was that she would draw together high quality practice, really good research and education, so that people in the UK and further afield could die well and survive bereavement. Last year marked 10 years following her death. We had an extraordinary event at St Christopher's, and I was struck. I met so many of the people for whom I've only ever read their books. So just in that line there, you've got Robert Twycross, who did extraordinary work around pain management, Colin Murray Parkes, you've got Tom West at the end, and a whole variety of pioneers who've really led the way. So it's an extraordinary place to live. Barbara Monroe, Dame Barbara Monroe was my predecessor. She did an extraordinary amount in the UK and was the vice chair of the Commission into the Future of Hospice Care. And this is Sean, and he and I share the job of chief executive, and he's holding the fort at home while I'm enjoying myself here. So, just a couple of quick facts about St Christopher's so that I can put into context, and then I'll move on to the main presentation. We're one of the biggest hospices in the UK, and we cost about £19 million a year to run. I guess that's about, I don't know, 38 million Australian dollars. About a third of that comes from the National Health Service, the statutory sector, and the remainder we raise through fundraising, legacies and trading. And that for us is about £32,000 a day. And that's just how important our community is to us. We honestly couldn't survive. Last year, we looked after about 3,500 patients. We looked after 1,000 adults who needed bereavement support, another 1,000 children and families looking for bereavement support, and about 560 carers. And we reckon we reach about 6,000 people, but that is nothing compared to the need that exists even in our area. So that's the first challenge that we face in the UK, and I suspect you face that here as well. Let's move on then and think about the key questions that I'm going to focus on in my presentation today. And I do think we are at a crossroads. We've got some very key questions to ask about what hospice and palliative care does in the future. Who do we look after? How do we best meet their needs? How do we position ourselves in relation to those who need our help? And then how do we position ourselves in relation to other providers of health and social care? And I'm going to cover some of that in what I talk about today. I think you have to decide about some key principles that are going to guide your decisions around those really important questions. And we need to start by thinking critically about what are we good at? What are the things that we must perpetuate into the future? And then I think we've got to be equally as critical and say, what have we failed to achieve thus far that actually we're never going to do well, that we need other people to help us do better? We must ask where our blind spots are. There are so many things that we just fail to think about, look at, or understand. And I think very importantly, what can we learn from other sectors? I think for a long time in the UK, the hospice sector felt it really had nailed end-of-life care. It felt that it knew exactly what it needed to do and how to do it. And actually, if the government just gave us more money, we could make dying great for everybody. And we've never achieved that kind of coverage, but more importantly, we were wrong in that. We need the help of aged care, rehabilitation, community development, mental health, just to name a few. So let's start with the stuff that we know we're good at. And in the main, we're seen as a good thing. And this was the 2015 Quality of Death Index that was produced by the Liam Foundation. It ranked palliative care across the world, and Great Britain was at the top. Australia, I think, is number 2. New Zealand is number 3. Is that right? I can't. I'm completely struggling visually now. I'm talking completely blindly. I'm afraid. But what was interesting is that when the evaluators, the analysts, looked at where the UK sat, they recognised that one very important reason for our success was the strong hospice movement. And so that is something for which we should be proud. We know that hospice care in the UK is seen as an example of what can be achieved by others. This was the first end-of-life care strategy, national end-of-life care strategy for the UK. It was in 2008. It's very old now. But what it said right in its early bit is that much can be learned from the holistic approach to care, which has been pioneered by hospices and specialist palliative care services in this country over the last 40 years. And so whilst this strategy was probably one of the most important developments in our country, and the beginning of an acknowledgement that palliative care needed to be something done by everybody. There was due acknowledgement to the fact that the hospice sector had something to contribute in terms of the principles of care. We're expected to show others the way. This is a very salutary report produced this year. The Care Quality Commission is one of our regulators, but they did a piece of work where they looked at equity and equality of provision. I'm going to talk a little bit more about their findings, but their findings were not pretty. And they recognise that particularly for marginalised people on the margins of society, people traditionally excluded from healthcare, people got a pretty duff experience of end of life. And they charge hospices with helping to change that. They say hospices should champion an equality-led approach, engage communities, deliver equitable end of life, and support others to do the same. So we do have a role based on our history in helping the broader sectors to get end-of-life care right. We know that the public like us, and I'm sure that's true for you as it is in the UK. This is a piece of work done by Hospice UK. They look at all the hospice accounts, and the reason that I was going to show that to you is that our public are our most significant contributor of funding, and our public is raising huge amounts of money for us each year. That is quite salutary. I don't know how that compares to Australia, but they only give to us because they believe that we're doing a good job or that we've done something right for them. That's all the good stuff, and I feel proud to be part of the sector. I feel incredibly privileged to be working somewhere like St Christopher's, but I need to be, as I said at the beginning, equally aware of what we don't do so well. And we have our critics. And I'm going to go way back now to a document which probably some of you might remember, but it's so long ago, I had to go back into the archives to find it. It was published in 1992. There was a GP who wrote this utterly critical personal comment in the BMJ about the hospice movement. And he begins by saying, the hospice movement is too good to be true and too small to be useful. And he made a number of very critical allegations about the hospice movement. In fact, what he wants is its demise. And he's marking it. In 1992, he said, we've had enough. Thanks very much, you good and worthy people. Let palliative care become part of mainstream provision, and could you please pop off and do something else? And he says something very critical at the end. He says, the more adaptable palliative care doctors will find themselves made welcome in the real world, and the duchesses will no doubt set to work upon some other good case. Why not, for instance, a hospice legacy, a heritage trail? So he really felt we'd done our deeds by the end of 1992. And his key criticisms, because you won't be able to read that, but it's a very good, if very salutary read. His key criticisms of us, as I say, too good to be true, too small to be useful. A service that he thinks, for poor reasons, deliberately situated outside mainstream care. Lots of inequalities, particularly for people dying of conditions other than cancer. An important and central component of healthcare left to the voluntary sector. Expensive and inefficient. And a distraction to statutory services seeking to improve end-of-life care. So those were his key criticisms of us in 1992. I've no idea what happened to him, actually. I've never seen anything else written by him since. So how do we plead 20 years on, 23 years on? Well, I think we have to say, guilty, my lord. But I do believe there are some extenuating circumstances. So the first thing to say is, he says you're just too small to be useful. We have benefited from being small. Hospices in particular enjoy very little gap between the top and the bottom of their organisations, and you can influence both ways very easily. There are very few places where, as a chief executive, you can expect people who are doing the work on a day-to-day level to come and knock on your door and tell you where improvements are needed or where you've gone wrong. Equally, if you want to change something, you're able to walk up onto those wards and you know that you can speak to the individual who's delivering that care on a day-to-day basis. That's a real, that's something that makes quality, improvement and assurance so much easier than when you work through huge numbers of layers of people. We can be very fleet of foot in response to new opportunities. Relationships across the organisation are highly personalised, for good and for bad, and individuals feel responsible and accountable for the success of the organisation. And staff, certainly at St Christopher's, we've got staff who, I talk about them being boomerangers. They've gone away, they've come back, they might do a variety of roles within the organisation, and they truly understand and love the organisation and its work. And that will only happen when you're in a relatively small organisation. I love this piece of graffiti. It's on a wall in East London. It says, if you think you're too small to make a difference, try sleeping with a mosquito. And I think, indeed, the hospice movement, despite being small in the UK, has had a profound impact. There's a very strong argument, I think, for sitting outside mainstream care. This, again, is a very old piece of academic work. It's a terrific piece of writing, and it's in the sociological literature. I think it was written in, I'm so compromised, I'm so sorry. I think it was written in 1992 by Nikki James and David Field, and it was about the bureaucratisation of hospice care, and they looked at Weber's model of charisma and bureaucratisation, and basically they said that, in a nutshell, they said Cicely Saunders had to come out of the mainstream provision in order to create and innovate, but there's a constant tension about moving back into it in order to transform care delivered by other people. So if we want to maintain the charismatic and pioneering founding principles of our care, maybe we have to sit outside the sector. Maybe that's what enables us to remain creative and highly responsive. And I think the other important thing is when we sit outside the mainstream provision in the UK, we attract people who are still highly driven by vision and vocation. They know that they can still make the kind of difference that gets them up every day. Our independence as organisations and a sector can be very valuable. We are regulated in the UK. We're regulated by something called the Care Quality Commission, but actually it's only one of a number of influences on our priority. We must pass when they come to assess us, but actually our definition of quality far exceeds their standards. They're the bottom. We're going for the top. Our targets in the main are self-imposed. We can choose what work we want to do. And I think very importantly, because we sit outside the NHS, we can decide who we collaborate with, and we can really enjoy opportunities as they come up for collaboration without having to make reference to an NHS board, without having to look at the relationship management policy and so on. Our community support. So remember that our critics said, listen, end-of-life care should not sit with the voluntary sector. It needs to sit with mainline provision. And one of the things that I would want to take issue with him is that actually if we'd sat always in mainstream provision, we'd have never enjoyed the community support we have. Most of the hospices in the UK, the 200 hospices in the UK, were founded by communities. They were founded by people who recognised that care was inadequate either for themselves or their families or their neighbours, and they got together with others and they said, look, we can change this. Let's raise money. Let's engage with the statutory services and create and build a hospice or a palliative care service. And even now, we certainly couldn't exist without community services. We have over 1,200 volunteers at St Christopher's. As I say, we raise about £12 million a year from voluntary funding. We have important connections via the community. We have champions. Really importantly, it's our community that tells other people not to be frightened of hospice care. It's nothing to do with our marketing that makes our difference. It's when somebody says, look, I knew somebody who was in there and it was the best thing that ever happened to them. Let me take you. That's what makes the difference. It's when our volunteers bring somebody else and say, she's been ever so worried about coming, but I've brought her in and she's having a cup of coffee and she's going to become a volunteer. That is who we depend on to break down the barrier between what people are frightened of and what they can get. I did work a while ago with Charlie Leadbeater, who wrote a fantastic document called Dying for Change. And he said to me, the biggest paradox for hospices is the fact that before people come into them or have care from them, it's the last place on God's earth that they want to be. And once they come in, you can't get rid of them. And he's completely right. And he said, what you've got to do is to try and find a way of reducing that significant barrier that's in between. Communities and volunteers, champions locally are the answer to that. Our community gives us regular feedback about what we're doing well and what we're not doing so well. There's real opportunity for co-design and co-production for services in the future. And of course, certainly at St Christopher's, community members are our trustees. So they are governing us and guiding our future direction. So, I've talked about what's good, I've talked about some of the mitigating factors in response to criticism, and here's where we are today. We have got a philosophy and an approach to care that is enduring. Cicely Saunders had this very famous quote that nobody will need me to remind you of, but it's so important. You matter because you're you matter to the last moment of your life, and we'll do all we can not only to help you die peacefully, but also to help you live until you die. And I think if you came to St Christopher's today, I hope you'd still see that people feel valued even as they approach the end of their life, that we focus on the quality of their life and helping them to live well and to live with self-respect even though they are coming to the end of their life. And there are very strong working links that remain between practice, education and research. And I'm sure those tick boxes would be true for you as well. This is a lovely poster done by a group of senior volunteers who came to our hospice for a day, and they basically took photographs, talked to people about their experience of coming to St Christopher's, and overwhelmingly positive. People were really delighted with and pleasantly surprised by their experience. And there are a few quotes in here, I won't read them, but it's about person-centred care. It's about the art and the science of good end-of-life care. It's about recognising that families have got a whole journey of bereavement once somebody dies, and all the stuff that you and I know is our bread and butter. We also are able to continue to innovate in response to new needs. So I won't go through this, but we've got a very interesting new coordination centre at St Christopher's. It's looking after everybody that traditionally hospices haven't. We've got the highest non-cancer. We've got 80% of our patients in our coordination centre have a non-cancer condition. 65% of them are over 85. And they are all people who are deemed to be in the last year of life, and they are living with high levels of frailty. Now, we have never captured them before. They've always been outside of our criteria, and I'm so pleased that at last they're able to get gain some benefit from us, even though it's a different service. We've got a personal care service that's about social care in the home. This is about provision that goes in to get people out of hospital and enable them to be cared for and die at home if they wish. We've got in that service a 76% death at home rate. It's the best death at home rate we have in our organisation. We've just started vocational accredited training for carers, people who work in care homes and in personal care agencies, because they are the people who are doing the majority of end-of-life care in the UK, and they have appallingly small amounts of training, and yet they're carrying and looking after the majority of people who need high-quality personalised care. And I don't have time to talk about this, but this was a programme of innovation at St Joseph's where I was the clinical director, which is about building community capacity, about encouraging people from minoritised groups to take responsibility and to enjoy reaching out to their neighbours and their friends. Very importantly, we're good at the experience, we're good at the art, so do we really make a difference? I've been working with Fliss Merter at King's College London on some outcome measures. It's a programme called OAK, you might know it. It's the Outcomes Assessment Complexity Collaborative. And what I can tell you is that even when people's dependency is rapidly becoming greater, so even when people's Karnofsky scores are going up and up and up, people's symptom burden is reducing. Now, that is a fantastic piece of evidence. For the first time ever, when people tell us that we cost a lot and we're inefficient, what we can tell them is that even when people are highly dependent and their conditions are advancing, we are managing to reduce symptom burden. You and I knew that anecdotally, but we've never had the data before. So that's very good news for us. That's the good stuff. Here's where we have less mitigation. We've done appallingly in the UK around inequities and inequalities in our care. And we know that actually in the UK, from about 500,000 people who die a year, 100,000 people don't receive palliative care even if they would benefit from it. People with non-cancer conditions continue to be excluded. People who've got active cancer treatments with haematological cancers are very unlikely to be referred to palliative care services. The oldest old, that's 85 years plus, get disproportionately little palliative care, and there are some pretty poor outcomes for some groups, particularly those that are socially excluded. Black and minority ethnic groups get a particularly raw deal, and they get lower access, poorer experiences of care, and poorer outcomes. That's very disappointing. And of course, for some BMA groups, they have higher incidences of particular conditions that require palliative care. And lesbian, gay, bisexual, transsexual communities are in the same boat. And there's been some really very good recent research from King's College, and there's a good report from Marie Curie, which just confirms that actually very often they fail to get the right communication. They delay accessing their care. They're more unlikely to have good symptom management, and they're likely to die more uncomfortably at the end of life. I spoke earlier about this report, so I won't go through it again now, but just a very challenging finding from the Care Quality Commission review this year, which that if you already live on the margins of society and you are excluded from wider health services, you're even more likely not to get good palliative care. Aren't we all built on the issues of social justice? This is very, very sad. So, why is this the case? The first thing to say is that actually, even though we care very passionately for an individual, we often fail to look at the population that we serve. So our focus is on the person that's in our bed, and we fail to remember the many who are either waiting to come in or who are on a waiting list, or who've never even been referred into palliative care. And that's one of our blind spots. That's what I was talking about at the beginning. So, last few minutes. How am I doing?
You're going very well, and I'm inclined, and this is rare for me, to let her go a little over.
That's good. So I'm going to slow down a little bit then to talk about the answer. Thank you. Really importantly, and perhaps you're all good at this in Australia, we're not in the UK. There is something about adopting a population-based approach to planning and reviewing services. Your minister spoke most eloquently today about the enormous changes in demography and epidemiology that we're going to face. And we need to think very hard about the age of people who are likely to need our care, what kind of illnesses they will have, and the kind of time of life in which they're going to die, where they're going to die, their ethnicity, because that's usually a mark of inequality, levels of deprivation, whether they live alone or with other people, and the numbers and the nature of the family carers. In the UK, we're moving more and more to what's called a beanpole structure of families. So historically, our family structures look like this, with lots of children and lots of grandchildren who are able to provide practical, financial, emotional support to older generations. Now, the number of children that exist to look after older people is getting smaller and smaller, and it looks, as I say, like a beanpole. And with blended families, I met somebody last week who's an only child who's got 7 parents to look after. You know, she's had parents who've then divorced and remarried and divorced and remarried, and she's got children, and she's somewhere sandwiched in between, and it's tough for her. So we need to think very hard about the kind of population that we're serving, not just the problems presented by the man who comes through our door. The map on the right, we have something terrific in the UK called the National End of Life Care Intelligence Unit, and it started to do a lot of data around our populations, our local populations, and that's where we need to move to as we think about what we should be doing in the future and how. Here, if you've listened to nothing else today, this is the bit that I really want us to focus on. And this is about shifting our focus from believing that our priority sits with getting more statutory money, fighting with our statutory commissioners, influencing government. I think our answer is about placing patients and the public absolutely at the centre of the plan to change their experience of end of life. Now, this isn't just a rehash of person-centred care. I'm not saying put them at the centre of the care. That's what you've been doing for years. I hope that's what's happening today for everybody who is receiving care at St Christopher's. I'm talking about the locus of change for the future. And I'm giving up, I'm sad to say, with trying to fight my statutory commissioners around targets and contracts. I'm moving the other way. I'm going to start investing my time and my energy in empowering the patient and the public to change their own experiences of end of life. And I think we have a number of ways of doing that. I think we could really upskill people. That might be a role of hospice and palliative care in the short term. They need training. Carers, I regularly hear from carers who say, thanks very much for the help, it was good, but I'd have liked to do more of it. I would have liked to be able to do what that nurse was doing, but nobody's ever actually taught me so that I can do it confidently. Maybe that's not a case for you, but it certainly is in the UK. People have very little sense or experience of entitlement. They don't believe that they can push for good end-of-life care. A lot of people who come into the hospice are profoundly grateful. Why are they grateful? Because they've had a terrible experience before they've got to us. It's not because they believe that they should be entitled to a good end of life or support in their bereavement. Advanced care planning must be key. and it starts with people like you and me. I've got a very interesting PhD student. She's doing a lot of work around community participation, and actually the most extraordinary finding of hers for me is that actually the befriending provision isn't really changing the experience of people right at the end of life. They like it, but what's really happening is that the people who are the volunteers now are the people who are saying, no, I need to plan my end of life now. I've realised it's a bit like you don't start making your decisions about where to have your baby when you're in labour. It's too late and it's too emotional and you're too preoccupied. You want to do it right at the beginning. And that's been a big moment of awareness for us. And I think the other thing is we need to teach new people new behaviours to achieve what they want. I do some work with a community development organisation in East London. This is primarily about empowering people who are on the margins, and one of the things that they described was that they had very poor experiences of visiting their general practitioner. And so the organisation, with their help, taught them two behaviours. They taught them that when they went into the room where they come for their general practitioner consultation, the first thing they did was they came in and they said, "Hello, doctor, how are you today?" And immediately it changed the power differential. And they said most doctors didn't actually respond, but some, of course, said, you know, thank you, yes, fine, thank you, come in. And the second thing they were taught was that every time the doctor started to look at the computer and to start typing, to stop talking, which forced the doctor to look back at the person. Now, none of those behaviours are naughty, but they're utterly empowering. And it's those kind of behaviours that we need to teach people. Yes? Yeah. We need to help build a variety of people and resources around patients and carers so they have a repository of help. And you're going to hear so much more about that tomorrow in the keynote talk. I've really had to sit on my hands not to spend the whole of my 40 minutes talking about why I think this is the way of the future. But I just want to make reference to work that's been done in this country by Debbie Horsfall and her team in Sydney around networks of care and how much that's utterly influenced the carers' experience of dying, but whole communities as well. And these are networks where people drew lines according to who they knew in the community and how strong it was. And before caring, it was pretty sparse. After caring, it's greatly enriched. And that was some really nice research about when people die well at home. That's what happens. This is a systematic review that we did of literature around community development and impact. Libby Sauno was the lead writer on this, and there were three things. It made a practical difference to people, individuals learnt and grew, particularly the volunteers, and there was much greater community capacity. And Libby's work, where she's evaluating compassionate neighbours in East London, has gone on to show some significant impacts. Changed attitudes, increased well-being on the part of patients, the public and volunteers, the opportunity for new relationships, and strong social capital. That's about relationships within groups and across groups. This is unpublished at the moment. There should be a good publication for this towards the end of the year, but it's very, very exciting. When she did her work, she looked at what made the best, what were the best facilitators for engaging community in end-of-life care. And it was around a common vision and purpose. It was about a recognition that it's not about I care for you and you need me. It's about mutual need. It's about mutual opportunity. Hospices did have a role. That's fascinating and important for us. The training mirrored the practice, and a lot of the training was about life skills. I was part of yesterday's pre-conference discussion where people were talking about what training do volunteers need. And one of the really important thing about this work is that actually a lot of the training is about life skills. It's about knowing yourself, knowing your boundaries, communicating well, reaching out to people who are distressed. It's not about safeguarding. It's not about, do you know what to do in a fire alarm? Are you handling food correctly? All the things that we're totally preoccupied with at St. Christopher's. The other important thing is that working across groups and communities at St. Joseph's, where this work happens, there are 14 languages spoken by the volunteers who are involved, and they all are getting to know each other. And it's not just about ethnic mix. We've got a good LGBT elder group there, and what they're doing is they're finding bridges, they're finding connections, and they've got this shared aspiration, which is to change the experience at the end of life. The other thing that we need to do, I think, so is there a role for hospice? There is. It's about providing professional expertise and services from which the community and patients can draw when people have particularly challenging problems. It's about care around the clock. I refuse now to talk about out of hours, because as one carer said, whose hours? Exactly. It's about identifying gaps and thinking about who's best placed to respond, and it's about focusing on empowerment through training. It's not about doing unto people, it's about helping them learn new skills so that they can do it for themselves. And near lastly, there's something about coordinating and supporting the input of others to meet identified needs, whether that's about other voluntary sector organisations, other health services, other specialties, equipment, social care. That's a role that we can have. I'm going to draw this together, so if you think you're losing the thread, we'll come back and I'll show you how it all fits. And very lastly, we mustn't forget, I started by saying I'm focusing much more now on empowering individuals and communities, but we must seek to influence government and other leaders about opportunities to further develop the system. One of the things I'm really struck by with Palliative Care Victoria is that you use stories a lot to sell the work that you do. And that's very important, and it's a role that we must have as we try to influence government. We need to talk about opportunities for further investment. How do we move very finite resources from inefficient services to stuff that can have a greater difference? And Emilio, I'm sure, will talk much more eloquently about that tomorrow than I can today. We need to measure. We must have our outcome measures, because when we are really criticised for being expensive, we need to know that we're making a difference, that general palliative care services, with all the good things they do, can't achieve. Those patients I was describing whose outcome measures improve even though their condition is worsening, they are people with severe symptom burdens. We do have a role in looking after them. We need to think about further integration, and that's about integration around the person. Integration in the UK is usually about saving money. When the government says health and social care is going to come together, they're not thinking how will this improve the experience for the patient. They're thinking, oh, that could mean a few less £1 million spent in having two different organisations. And actually, real integration is about bringing together the care and the support of lots and lots of different people. In the UK, they reckon about 28 professionals are involved in somebody's care at the end of life. How on earth does somebody manage that? And then I think the other important thing that Emilio again will touch on much better tomorrow is about highlighting the opportunities for community participation. So I'm now at the end, and I'm going to try and summarise. So we've talked about what we do well, we've talked about what we do less well, and I've given you some suggestions about what we might do in the future to change the experience of people who are dying and bereaved in a sustained and a substantial way. And just to finish, I want to just draw that together. I think it is primarily about empowering the patient and the public. That's where I'm going to focus my efforts. And I'm going to try and help build communities around them. that role for hospice and palliative care might be short-term. Once those communities and networks are built, maybe we just let go and we move on to something else. But for now, Libby's research tells us that hospices have an important role to play in that. And that's where we have a strategic priority at St Christopher's, which is about empowering the public around death, dying and loss. And it is about building communities. Once we've built communities, there's something about continuing to provide professional help for complex problems. I'm not saying for a minute that communities alone can deal with everything. They can deal with a huge amount, but there are still needs for the kind of expertise that exists in places like St Christopher's. And then there's something about our role in facilitating the input of others. How do we coordinate those 28 professionals? How do we ensure that somebody who's dying with heart failure gets access to the right cardiac support whilst also enjoying good palliative care and enjoying good quality of life afforded by their neighbours and their friends? So we've got a role there. And of course, the fifth thing is all about influencing government and other leaders. We do need to continue to do that work. I can honestly say I was blown over today by the knowledge, the in-depth knowledge that Kim Peake appeared to have, and her commitment well beyond a couple of stories of how great somebody's death was to the realities of the future. You've got real potential there. If I had a government minister that came to talk to a conference in the UK who was that knowledgeable, I'd be very, very excited. Very finally, but importantly, all that needs to be underpinned by a thorough understanding of the needs and the capabilities of the local population. That's your needs assessment. But it's not just about who dies and where. It's about what potential exists. What assets have you got in your community that you can draw on to achieve all of those ambitions? Last thoughts then. St Christopher's is 50 years old next year, and we have some fantastic celebrations planned because we have got an enduring vision and we've got much to be proud of. But actually, just as we're planning our 50-year celebration, we're also saying, actually, we've got to do much, much more in the future. And we're building a new education centre that's about training local people, about training carers and patients to look after themselves better. There are real opportunities to build on our unutilised strengths. People like our volunteers, our communities, that's something we need to do much more on. We need some radical rethink. We need to think very carefully about what we can draw from public health, and you'll get that opportunity tomorrow. We need to think about how we enable real integration that's focused on changing the needs and experiences of people at end of life, not the bottom line. And most importantly, we actually need events like this. We need global thinking. The UK definitely doesn't have all the answers. Australia probably doesn't have the answers. But between us and other parts of the world, we could start to get to the bottom of a very complex problem. Thank you very much.